Walk up here.
I'm with Illinois Bone and Joint in the Chicago division downtown here. I think of myself and my scope of practice as really a comprehensive adult hip specialist. I'm one of the most comprehensive individuals in the city and surrounding suburbs of Chicago. And with my practice focuses on hip replacements. I'm a specialist in anterior minimally invasive hip replacements without the use of any special cable. I do complex hip revision procedures. From hip preservation surgery, this is surgery and evaluation treatment of adult patients with hip injuries that don't require hip replacement. Common articular cartilage injuries we'll talk about, in more complex surgery with correct underlying deformities is kind of outside the scope of this presentation. And a fracture specialist of the hip and proximal femur. I don't have the official disclosure side, but I have nothing to disclose except my wife is a lawyer by schooling, so I've learned very quickly not to argue at home, and she's always right. I tried to put together a clear, stepwise approach of thinking about the hip. The hip is a ball and socket joint, but there's a lot of pathology and acute injuries that can occur about the hip that I see in a routine basis, especially from a medical legal standpoint. Fractures are pretty clearly easy to understand because they're breaks in the bone, but the type of fracture pattern really matters and dictates treatment. We'll go through that first. Labral tears or cartilage injuries are increasingly recognized in the hip, and that's a huge part of my practice. Aggravation, we're talking arthritis, specifically aggravation of pre-existing arthritis as it relates to the injury patient. Muscular tendon tears throughout the hip, referred pain from the lumbar spine, and abdomen is important. And I was going to touch on avascular necrosis because that's a very litigious topic as well, because it's a significant pre-existing condition that can show up in some of these patients. To start with, I think of the hip kind of like a layered approach when I'm describing and thinking about it. We're going to start simple with bone. The hip is a ball and socket joint. The socket is called the acetabulum. It's part of the pelvis. The ball, or the proximal femur femoral head, comes down into the neck region and ultimately the intertrochanteric region down here. So you end up at the femoral shaft. So we're going to go through fractures of the hip first, starting from the top down, focusing on mainly the femoral side. I did not include the socket side fractures or acetabular fractures. So femoral head fractures we're going to touch on are fractures of the ball itself. Femoral neck fractures are very important, significant fractures to understand the treatment ramifications of it. Intertrochanteric fractures is as you march down the femur. And then finally, subtrochanteric fractures are just below the region where a lot of the muscles attach to and in the top part of the shaft of the femur. So there's several factors that dictate and determine treatment. I touched on the location first off. Patient's age is really important for the treatment of femoral neck fractures, which I'll expand on. The fracture pattern is important to me in terms of how to treat the fracture, how to fix the fracture. That's important to you. But the majority of these fractures are really surgical treatment, surgically treated. Patients bedbound, they cannot, this is a fracture of urgency and necessity, usually to be fixed within 24 to 36 hours. Rare non-displaced stress fractures can sometimes be treated non-surgically, but the majority of these go on to very quick surgery and have significant long-term ramifications. So before we talk about fracture pattern, the blood supply of the hip is crucial to understand. So the blood supply really dictates treatment in these fractures. The blood supply comes from in the adult hip, comes from the medial femoral circumflex artery, which is branched off a huge artery in the thigh called the femoral artery, and it kind of starts to branch up into the neck and the head. The best, easiest analogy, and I speak of analogies to help you understand things and my patients understand things a little bit easier, is to think of a tree run. A tree and the branching pattern of the tree. This medial femoral circumflex artery is the trunk. There's huge branches in this region, and as you go up, branches become smaller and smaller and smaller. So for those branches to survive and revascularize, and for anything above that to survive, becomes more difficult. So that's keep in the back of your head when we talk about treatment. So for femoral head fractures, these are relatively rare fractures. The majority are associated with native hip, meaning the person's own hip dislocation. These are high energy fracture patterns used in younger individuals, like a car accident or a fall from height. And the goal is typically to fix the fracture. Very rarely do you see these in anybody over the age of 50. In that case, it kind of gets a little bit more controversial what to do, but the majority of these are high energy fractures, and the goal is to fix it. These are significant fractures to understand from your perspective, and that they have, not only is they have a long-term risk of problems, because based on the blood supply, when you break the femoral head, you need that to heal successfully. The healing rate of that is a little bit less than, a little bit more than 50-50, but the odds are not in someone's favor. So that could lead to a need for additional surgery down the line. Sometimes that doesn't show up for years down the line, for several years. So it's important to keep a close eye on these patients and not dismiss them that they're better at 6 months. Because at a year, even up to 4 years out, it's been reported that they can develop either post-traumatic arthritis or post-traumatic avascular necrosis that needs additional surgery with a hip replacement. As you march down the neck, the most controversial of these fractures is really femoral neck fractures. Non-displaced fractures sometimes are missed on plain x-rays, and the imaging modality of choice is really an MRI. Even they can be missed on CT. And I've seen patients that have had a CT and they had a high eliciting suspicion and they still need an MRI to really diagnose these. The majority of them are fixed surgically although they're relatively stable, you fix them with generally these 3 cannulated screws to provide some compression, increase the rate of healing, and allow the patient to mobilize. The flip side of not treating them surgically, even though they're stable, the patient walks on and twists, then it becomes a displaced fracture, which we'll talk about next, and it becomes a whole different bucket and a lot of problems. So that's why we really encourage fixation. These generally heal pretty well. Both of these low rate of avascular necrosis or interruption of blood supply where they need a subsequent hip replacement. Displaced femoral neck fractures are a whole different animal. These have a high rate of post-traumatic avascular necrosis where you have an interruption of the blood supply at the time of the injury. So fixing them really depends on the patient's age. If it's an older individual, then we move more towards the hip replacement, because if the odds are against them in terms of fixing it and they need a second surgery in 6 months, it's probably better to do 1 surgery initially. And as I'll touch upon later with hip replacements, it's become such a successful surgery that the overall success and odds of failure are a lot less. Versus a younger patient, we attempt to salvage the hip and fix it. But the goal is to really, these have to be fixed urgently within 12 hours to try to reestablish the blood supply. You let them sit, their prognosis is really poor and requiring subsequent hip replacement down the line. As you march down the femur, the next area is the intertrochanteric region, and kind of group these together with subtrochanteric fractures because this area of the bone in the hip is encased with all the muscles that attach to the hip. Therefore, it has a tremendous blood supply. They heal pretty reliably, and they're fixed. We don't really think about hip replacements with this. There's really 2 methods of fixation that you might see. What's called a dynamic hip screw or plate and screw construct to provide some compression across the fracture, or some kind of what's called a cephalomedullary nail or titanium nail that runs down the middle of the hollow part of the femur, and then a large screw or a couple screws that go into the femoral head. They come in several different variations, different lengths. You can have a shorter one run along all the way down to the knee, but the premise is the same. Afterwards, these are significant injuries. These injuries take most people 3 to 6 months, upwards of a year to recover from. The good news is that the majority of these patients can be weight bearing and tolerated. They need extensive therapy, and we really keep a close eye on what happens to the blood supply and the healing. If the blood supply is interrupted and the valves start to die off, then these patients have very poor prognosis and need additional surgery with a hip replacement. So usually for a typical fracture, it's a maximum of improvement, usually a year, but depending on the post-op reports and any complications. When you look at the hip, the next layer that we're going to touch upon is inside the hip joint. Inside the hip joint, is mainly cartilage. You heard a lot about cartilage during the last talk. Cartilage is an avascular structure for the most part that doesn't have a blood supply. It's a little bit not true in the hip, because the hip has a special rim of cartilage called the labrum. It's this rim of cartilage that I was laying on. This is commonly injured in the hip. It does have a good supply, and we fix it routinely. Other things in the hip that can be injured but less common and a little bit more controversial would be the joint capsule, the ligaments that make up the joint capsule, and the ligament teres, which is where the embryonic blood supply in the hip comes into, usually about birth to about 3 years old. You really don't have a great understanding of it. There's been some literature and some guys advocating that you see patients with injury to that or tearing of that and they go in and breathe that, and that's a little bit more controversial. So to touch on the acetabular labrum, we'll talk a bit about that next. Acetabular labrum, I think of kind of like a suction cup sealed to the hip. It's this horseshoe rim of cartilage around the hip socket that surrounds the hip about 270 degrees. This is what a nice, normal, young, healthy one looks like a young teenager when you look at it. To step aside for a second, if you look at the natural history, some of the natural history, so for the tears, they can be partial thickness tears, where you can get the cartilage rim partially torn away. They can be full thickness, where it's a bulge from the bony rim of the hip socket. They can be somewhat more degenerative, or a combination where you have some intrinsic damage to these. They can be traumatic, but they're often associated with underlying bony deformities, and that's the next key thing to understand about it. This concept is called femoral acetabular impingement syndrome, or FAI. This is due to some underlying abnormal bony deformity that the patient was born with, developed. We think it's a developmental phenomenon in the teenage years in young active individuals, and it's caused by repetitive injury to the growth plates around the hip. So it causes abnormal contact between the proximal part of the femur and the femoral neck and the hip socket, and particularly the cartilage rim or the labrum. And it's thought to be the predominant source of arthritis of the hip, especially in patients that end up getting arthritis in their 40s, 50s, and even early 60s. They have some kind of bony deformity that precipitated and caused that. So there's two main types. You have a deformity on the femoral side, or the bulb. This is referred to as a cam deformity because in machinery there's the cam of a dry shaft. Or there can be a socket deformity, in which the socket's a little extra deep or has this pincer deformity. So the premise is the same, that anything non-spherical causes abnormal contact between the edge of the hip socket, in which the labrum is attached to here, and causes repetitive damage in separation of that. Whether that's acute at one point, or whether that's slow repetitive damage, it depends on the patient. So that abnormal aspherical femoral head is basically jammed or pinched against that cartilage rim over time, or from an acute episode, and causes this damage to the cartilage rim. When I look at patients, and look at patients' x-rays and try to explain this to them, from the femoral side, or the cam deformity, I like to think of the ideal hip looking like a light bulb. If you look at these x-rays, the back of the hip looks nice and concave, where the front of the hip has its convexity. So that convexity rubs against the cartilage rim, causing the damage. Where ideally, this hip should look like a light bulb, and all that bone should be removed. Pincer deformity is a deformity on the socket side, where the socket's very deep, and then you get a similar deformity, but it's because there's an abnormal contact from that extra deep socket. So to back up a second, I pulled this literature because this is important to understand, especially in your field. So there's like back pain and disc pathology in the lumbar spine. There's a huge incidence of labral pathology in asymptomatic individuals. So there's been several series of MRI studies in asymptomatic young individuals to look at labral pathology. In 101 asymptomatic individuals, young patients ages 11 to 19, they did MRIs, high-quality 3T MRIs on these patients. They had almost a 90% incidence of labral pathology, either partial thickness or full thickness tears in asymptomatic individuals over the age of 16. That's probably the highest incidence in any of the studies that are out there. Similar one in 45 asymptomatic individuals, a little bit older age population, 38. 69% of the hips had labral pathology. And in similar series, kind of middle of the road, about 38%. So I quote patients that conservatively, 40% of patients have some kind of labral pathology. So patients that come to me with an MRI from somewhere that shows they have a labral tear, it's upon me to determine if that's the source of their pain or if that's truly the pathology that's causing their symptoms. So to get there, I think that history is important. Hip pain, either whether it's labral pathology or arthritis, pain, the description of pain, if they have pain sitting, standing, stairs is important. Location, patients with hip pain commonly use the C side, but sometimes patients present referred pain down to their knee. Classic orthopedic test question is a young kid comes in with knee pain and nobody examined their hip. It's actually referred pain to the hip because the same nerve, specifically the operator nerve to the hip, travels out to the knee and causes referred pain. I have several patients like this. I see people for second opinions that have had knee scopes and nobody bothered to examine their hip and their knee pain never went away, and they had terrible hip arthritis. So aggravating the factors, usually rotation maneuvers of the hip, getting in and out of the car, putting on shoes, going up and down stairs aggravates the hip. The one single physical exam finding is called an impingement test. So that reproduces trying to pinch that labrum against the cartilage of the hip socket. So with that, flex the patient's hip up just past 90 degrees, adduct, internally rotated, you get that abnormal area of the femoral head neck junction to pinch against that labrum to see if that reproduces that pain. That's a pretty reliable test, not specific, but reliable. And that causes abnormal contact with the labrum. When imaging these patients, always begin with plain x-rays, look to make sure they have no underlying deformities, arthritis, which we'll touch upon in a few minutes. I look at, very important, the side views of the hip to look at any underlying bone deformity, such as this patient that has, as we touched on before, this aspherical or PAM morphology, their proximal femoral head neck junction. The mainstay of diagnosis is MR arthrography. It has to be an MRI arthrogram, where the radiologist gets a shot of contrast into the hip. And then this labrum, normally it's a dark black triangle on the front of the hip. The contrast leaks between the bone, which ends there, and the cartilage rim indicating the tear. So that's seen there, and then on other views of the hip, when you're looking at slicing the hip from the front to the back, you can see it there, and slicing the hip from the side, you see the same things. So an MR arthrogram of the hip is very sensitive and specific, versus if you get a non-contrast, run-of-the-mill MRI of the hip, it's very easily missed. You can see it maybe on 30%. If it's a decent quality, but the majority of these patients, I have to send back for a second MRI arthrogram because nobody ordered it appropriately the first time. From my standpoint, I think that a diagnostic, what I call diagnostic therapeutic hip injection, is the single most important study. I put more weight on this than the MRI. And the reason being is patients can come with various complaints, various pathology, refer to me from their back, and it really solidifies the diagnosis and the location of pain, and I call this the money shot. I give patients in my office, I take them downstairs under fluoroscopic or x-ray guidance, and give them an injection in the hip under x-ray guidance to confirm an intra-articular with 4 cc's, relatively small amount of local anesthetic, which kicks in 5 to 10 minutes, lasts about 4 to 8 hours, and cortisone. I keep these patients in the office, make them sit in the office for about a half hour, and re-examine them before and afterwards to make sure I document any change in their symptoms. If they have true intra-articular hip pathology, labral tear, arthritis, they can see dramatic improvement. And I think this is very important when solidifying the diagnosis and moving forward with treatment. Some patients are hesitant with cortisone, so I just do local anesthetic. From the therapeutic side, I explain to patients that cortisone can calm down some inflammation. Some patients with partial thickness labral tears or pre-existing labral pathology that got aggravated, sometimes they seek significant relief. Overall duration of relief, though, is very unpredictable, but it's something to try, and I think the more important part is to solidify and improve the diagnosis with this. So treatment options, non-surgical, like anything else in orthopedics. The patient attempts activity modification on their own, oral anti-inflammatory, Tylenol. Physical therapy is important for these patients preoperatively. There's been research and studies into physical therapy, and patients can get better with therapy. This is an older study that there was, out of 37 patients after 2 years, there was 11% crossover rate for surgery, but patients do have the potential to get better with surgery. If they fail these non-operative treatment options, surgical treatments can be accomplished really through 2 avenues. Majority of patients in my practice is through a hip arthroscopy or a hip scope. More complex deformities, I do an open surgical dislocation, which I'll touch on. And it really depends on the pathology and associated particular deformities, any pre-existing deformities. So the purpose of the surgery is twofold on whatever you're doing. 1, to address and fix the cartilage there, and 2, to address the pre-existing bony deformity so it doesn't continue to cause problems and re-tear in the future, and to reshape the front of that. So that's done with suture anchors that drill into the bone, loop around the cartilage rim to pack it down. There's a blood supply at the edge of the bone that allows it to heal. And these heal very reliably. Number 2 is to reshape the front of the bone by burring it down with a special burr and taking through a special range of motion in the hip on a special table. And I can reshape the front of the neck to make it look however I want and to give it an ideal concavity so it doesn't continue to rub in the future. Conversely, if a patient has more complex deformities, I do a complex procedure called a surgical hip dislocation, basically cutting the side of the bone or the trochanter where all the muscles attach. That allows me to take the ball out of the socket to address any cartilage injuries to the femoral head. We talked extensively on this in the last case. I basically do plugs where I fill this with into outer plugs. It's the most reliable in the hip versus taking and trying to harvest cells and going back. And here you can kind of see the labral tear away down in the hip there. That's the hip socket. That's fixed with a couple screws. You can see the difference afterwards of reshaping the neck there. These patients do well. Overall, my preference and most patients' preference is to have it done through a scope or through 3 to 4 incisions off the width of your finger. Less invasive, less risk of hardware irritation, overall faster recovery. And the outcomes are really all over the board, but generally pretty good outcomes. It's important to understand who doesn't do well. And patients that don't do well, and that's key to select these patients, is pre-existing degenerative changes and early arthritis. And to me, any patient with any joint space narrowing on a plain x-ray is not going to do well. They're going to have a high incidence of continued symptoms and arthritis and wear within the hip. They're better off with 1 surgery and having a hip replacement. The middle-aged female that's very high level, high demand, likes to do yoga, Pilates, everything they want to do with any pre-existing changes does not do well. And it's very mixed from my experience. Abnormally shaped hip sockets, you're not addressing the underlying deformity, I'll touch on that. And if you don't take enough bone, they can continue to rub and re-tear. But hip dysplasia, to touch on this, is a whole different animal. This is usually not an acute injury, but maybe somebody that has pre-existing abnormally shaped hip socket. This is really a complex deformity because you have to address the underlying deformity. Just like you talked on the last page, you have to address the clean alignment. We're very orthopedics care about the underlying structure. So for this, in normal hip socket, we measure the angle covers the hip about 25 to 35 degrees. This one covers the hip for the coverage less than 10, so that's a very shallow hip socket. Over time, there's a lot of edge loading that occurs because it's not able to distribute over the entire socket. You load the hip on the edge, that can cause premature arthritis of the hip. So to correct that, we do what's called a perioscapular osteotomy, where I make several cuts, bony cuts, to cut the hip socket basically away from the remainder of the pelvis. That's why it allows me free rein to reposition it and screw it back into place. This is a niche procedure that I do. These patients in the correct protocol have a pretty high rate of return to sports, but they have to be the correct patient, and you can't really stretch the boundaries of this. Next main topic is hip arthritis. In this population that we're talking about with you, it's really aggravation of pre-existing hip arthritis. I see a lot of patients and they have a slip and fall or some kind of injury, and they have they had no prior symptoms, and all of a sudden they have a flare-up of their hip arthritis. So hip arthritis, to back up a second, if you look at normal joint space of the hip, you can measure it on x-rays, typically 6 to 7 millimeters. Arthritic hip, you lose that joint space. Going back to analogies, my simple analogy I like to tell patients, even have this diagram in my office, it's like a Goodyear tire in your car. There's the cartilage represents the tread, and you've worn down the tread. It's a Goodyear tire, your hip is 60,000 miles in, 75,000 miles in. For a patient with really bad arthritis, I tell them to ride on the metal rim and their sparks going down the road. That usually gets the message across. Treatment options are very similar. In the injury patient, especially if it's orthotic or personal injury, I think giving them a cortisone injection and establishing that that's the source of their pain is key. The likelihood that they'll get better from that alone is very unpredictable. But it's an initial step, and it allows the acute pain to settle down and gets them into therapy. If they fail non-surgical things, their really only alternative is hip arthroplasty or a hip replacement. There's 2 kinds of hip replacements. I'll touch on that. For a hip replacement, it begins in my office. I make a preoperative blueprint and know exactly what size components, where to put the components. The premise is to remove the worn-out, diseased femoral head. I use special reamers to make a perfectly round hole in the pelvis, special instruments to make a channel in the proximal thigh bone. Hip replacement consists of 4 parts. It consists of a titanium stem in the middle of the bone. It consists of a titanium socket. There's a plastic liner called highly costly polyethylene, and the standard of care is a ceramic, or what's called BioLox femoral head these days. The metal components have a microscopic surface that resembles bone itself, so the majority of the patients, as long as the patient doesn't have severely weak bone, we use what's called press fit components, where after about 3 months, the components become rock solidly fixed in the person's body for about 3 months. Or sorry, the rest of their life, but that's after 3 months. There's several different ways to do a hip replacement, and how you do it really matters. I prefer the direct anterior approach, and that involves splitting the muscles in the front of the hip, avoiding to cut any of the major muscles. Get you down to the hip joint that's accomplished usually through an 8 to 10 centimeter incision, so about 2 to 3 inches in the front of the hip. Usually either an oblique incision for some females. I hide it in their underwear line. They call it 15 incision. Conversely, a regular posterior approach or mini posterior approach, you have to split the large gluteus maximus muscle in the IT band and you attach the short external rotators to the back of the hip. Once you get down to the hip, the premise of putting the components in the appropriate position is the same. The direct anterior approach that's been borne out in the literature in my practice is patients do better quicker. In the end, after about 3 months, it kind of levels out, but they have better pain scores, earlier independent ambulation, but after about 6 months, it's level out. But most people do better quicker. The only advantage of posterior approach is look at length of stay in the hospital is pretty similar. So, for example, so for this lady, 51-year-old, presents a second opinion for hip arthritis. She underwent anterior hip replacement, and this is her work. Now, that was her a week out from surgery, walking independently. You can barely tell that she had anything done. When you look at the longevity, and this is a classic question that's asked, when you look at the longevity, the literature we have on longevity is like long-term survival. It's on old implants that are 20, 30 years old, and the technology is changing dramatically. If you look at the components, the old components 30 years ago in the 80s, or even early 90s, you would have a high rate of cementing both the socket side and the femoral side in place. The plastic liner I'll touch on was the manufacturing process of that was dramatically different. So today, we use press fit components, and most importantly, the polyethylene, the plastic liner has changed dramatically. The manufacturing process changed around 2000 to what's called highly costly polyethylene, and that's a dramatic difference. Before, with the old polyethylene, you would be concerned about younger patients needing hip replacement. Either would wear out after 20, 30 years. You would see abnormal wear, where you could see the distance and that the femoral head's within the socket is eccentric here. That also leads to your body or the patient's body producing these little digestive enzymes to eat the particles that are worn. That also eats away the bone around the hip called osteolysis. It's a major problem that requires revision surgery. In modern hip replacements, they've been out since 2000. There's now a second study that came out last week. Similar population, young, active individuals less than the age of 50. I release these patients back to doing whatever they want, running any sport they want. There's 100% survivorship of wear. There's very little wear, if any, seen on plain x-rays. So I tell my patients that a well-done hip replacement should last them the rest of their life. A caveat, this is a fad I'm sure many of you guys are familiar with. It's hip resurfacing. Hip resurfacing is now a very small facet of my practice, but I still do it. It's meant for a very high level, high demand individual that wants to go back to a high level activity with no bone deformity, males with bigger head. There's one hip replacement that's left that's called the Birmingham hip resurfacing that has a good track record, but the components have to be put in the perfect position. The problem is, as you're familiar with, other metal-on-metal hip replacements have been withdrawn. There's all kinds of litigation associated with them because of abnormal metal debris. If the hip replacement is not put in the perfect position, it leads to edge loading of the components. The whole problem with the DePuy ASR saga is they tried to solve two problems at once, and they had a hip replacement, and additionally, instead of the cup being 180 degrees, it was 160 degrees to avoid irritation of the psoas tendon in the front of the hip, which precipitated this edge loading phenomenon even worse. These patients, and the correct patients, in people that know how to do them, I think do very well. It's not a less invasive operation. The surgery is twice as big of a dissection, but they have a high level of return to sport that they want to do. Marathon running, competitive cycling, triathletes, people like that. To switch gears for a quick second to be comprehensive in the hip and stay on the bony layer, I think hip avascular necrosis is important to understand. I mentioned this already. Hip avascular necrosis is an interruption of the blood supply where the bone underneath the articular surface starts to die off. Risk factors are classically chronic steroid use, excessive alcohol use, rare, what's called Casey's disease, which is the patient had diving history and came up with the bends. And the majority of these patients are idiopathic, and we just don't know why they developed it. And steroid use is mainly the patients that have chronic steroid use, such as for asthma or other autoimmune diseases. There's been some versus patients that received a single steroid pack at some point during their life for back pain or things. There's some genetic predisposition that we're starting to explore, but we don't understand yet. And the treatment of this really depends on the surface of the articular head. I think of it, and I describe it, thinking of my analogies, kind of like a sinkhole. There's a lot that happens before the ground collapses and you lose the pool in the back of your yard in Florida. That once the ground collapses, the cat's out of the bag and there's nothing to do short of a hip replacement. In a pre-collapse state, there's a lot I do. There's no true medications labeled for it. I use off-label osteoporotic medications, specifically for KO, which is medication, injectable medicine to build new bone. There's been small series that support that. You can go in, I go in and I drill a hole into the bone, into the lesion to try to establish blood flow to it. I usually couple that with bone marrow aspiration, where you take blood from the pelvis, spin it down in a special machine, and inject those stem cells into that lesion. And again, to collapse, you need a hip replacement. I included this because it's important to understand that I've seen several litigation cases, and when the patient comes in with a labral tear or slip and fall, and they have arthritis or pre-existing avascular necrosis that they were not aware of, and it's a hot litigious case for you guys. For me, they do the same thing. So coming up a layer is a muscular layer. A little less exciting, but there's still about 17 muscles that cross the hip joint. There's a few that are commonly injured, the culprits that I commonly see. Coming both superficial and proximal hernias, I feel everybody's abdomen, especially make sure they don't have any aspect of hernias or abdominal pathology that I've seen for referred pain to the hip. That they thought was hip pain was actually something in their abdomen, such as penile ovarian pathology. Sports hernias are a subset of hernias that are a little bit controversial, even if you talk to the general surgeons, and not everybody believes in them. I do. They're a weakening between the layers of the lower abdominal muscle, between the obliques, and it can be a source of significant pain. Usually it's kind of, you have to rule everything else out first, and then kind of the diagnosis of exclusion. Imaging with MRIs sometimes is difficult. Diagnostic injections with straight lidocaine can be helpful in this region. From a surgical standpoint, this is out of my realm, and I refer to these to general surgery colleagues that fix them either open or one of them does robotic nowadays. Iliopsoas tendonitis. Iliopsoas tendon is a large hip flexor in the front of the hip. Very rarely do you see hip flexor tears. I mean, maybe in an adolescent it's a classic person, but in an adult, you don't really see tears. You can see overuse. You can see tendonitis of it. That runs right in the front of the hip. They present with tenderness in the front of the hip. The main thing is to have them either seated or laid down and competing against resistance against straight hip flexion. I routinely inject this under image guidance in the office, like I mentioned before, for diagnostic purposes. Usually, sometimes it takes a couple injections to calm down. It's a big tendon, big wide tendon. It's like a big rope if you go in there and look at it. Also, very successful PRP in this region has helped as well. For refractory symptoms, you go in arthroscopically and release the iliopsoas tendon is really the controversial in my field, and the pendulum's really swung away from that these days because those patients lose a lot of hip flexion strength and can have some chronic pain issues there. Gluteal tendon tears I see a lot of, especially in the middle-aged female population, 50s, 60s. Sometimes they have pre-existing overuse tendonitis, they slip and fall, they have full-thickness tear identified in MRI. I describe that they present with significant, sometimes severe lateral hip pain. I describe it as a rotator cuff of the hip. Just like patients with rotator cuff syndrome come in with severe pain in the shoulder, can't sleep at night, these patients are miserable at night. There's two main tendons, the gluteus medius and gluteus minimus, that attaches on two different areas, what's called the greater on the top of the hip. Both you can have tendinopathy or tears of one or both of them. These are usually fixed in my practice open with small incision because there's such a tremendous force of these tendons that I fix them with a combination of suture anchors and drill holes through the bone and tie a large suture through that to get a great fixation. And MRI, they're identified. You can see the tendon in the white is where it should connect there, and it's torn off the edge of the bone there. You continue around the back of the hip, piriformis syndrome. I really think of it as a strict diagnosis, and true piriformis syndrome to me is based on the anatomy of the piriformis muscle and the sciatic nerve, which is a large nerve that goes down the back of the leg. The sciatic nerve typically, in most individuals, 90% of individuals, comes out under this piriformis tendon. About 12%, 11% of patients, it has some abnormal branching pattern and that it can split in the two, the nerve can split going through the tendon, or it can go straight through the muscle or tendon. These patients, when they present, they have sciatica-type symptoms of pain radiating down their leg, but it's mainly just when sitting, driving for a while, very focal symptoms, can have to rule out any associated lumbar spine pathology. Often I see therapists and a lot of people overdiagnosing it, that patients have piriformis syndrome, and this is what I think of as true piriformis syndrome. And finally, that leads to the last layer, and I think the neural layer is very important. As I touched on initially, referred pain to the hip is quite common. I see a lot of people for second opinions, or even from personal injuries that slipped and fell, initially was diagnosed with a lumbar disc herniation, been getting treatment for that. With lumbar epidural injections when they described pain radiating around through their groin, and nobody bothered to examine their hip or check an x-ray of their hip. And conversely, you see people come in with both back issues, hip issues. In this case, I go back to what I talked about before and really harp on is that diagnostic hip injection is key. It allows you to specifically and clearly identify how much pain is in the hip versus elsewhere, such as the lumbar spine. So I think the key to the hip, it's a complex joint, is to make the right diagnosis through precise history, clinical exam, image. I think diagnostic injections, I can't harp on enough, is crucial in my practice. And then making the right diagnosis leads to the right treatment and avoids any failures. I finished a little bit early. I don't think anybody's going to be pissed at me on a Friday afternoon. I'm happy to answer any questions. Go ahead.
So I just want to go right before we move to section 3 to section 4 at the end of the avascular necrosis section,
So when going back to those, I see a lot of patients with both. They get an MRI, they have some aspect of AVAS necrosis, and they have a labral tear, which we're looking for first. So in those patients, I go back to, I think that I give them a diagnostic injection. I think any pain from the labral tear goes away with that. Pain from the bone itself does not. But that being said, I usually address, if they're going to surgery, I address both. So I labrum, and then I do a 14 progression with those patients. Unfortunately, those patients are sometimes a little bit less predictable, that AVAS necrosis sometimes dictates the ultimate outcome. That's unpredictable process, and that progresses, unfortunately, that dictates the prognosis.
The case if you come into a labor, repair operation,
AVAS necrosis. So they're two very different entities. Right. Arthritis is different where, and if you have arthritis, you go into a labral treatment or repair, depending on the overall success of the surgery, depending on the health they have. A patient with more aware, like if you go to take care of my tire analogy, if you go, you take a trunk out of the sidewall, you get a curve, and that tire has 50,000 miles, they can kind of patch it aside, but it's not a great tire. So one, you can still give them a local anesthetic. I've had a couple patients that have allergies to local anesthetics and have changed local anesthetic, but the key is the local anesthetic in terms of the money diagnosis. In terms of alternative injections, cortisone is the main one approved. I use off-label use of viscosupplementation, which is FDA approved for the knee. Using the hip and the knee literature, about 2/3 of people get better. I would say my results in the hip are pretty similar to that. Also, I do PRP into the hip. It's considered a little bit more experimental. It calms down the inflammation, not regrowing through the artery with that. And that would be quite efficacious, but a little bit less predictable.
What's your opinion? Is there a somatic event that has an impact on the progression and acceleration of that disease?
Yeah. So her question was, what about the person that gets injured with pre-existing AVAS necrosis? And as I touched upon, that can be a very, I mean, from my standpoint, I treat the underlying hip and the pathology. From your standpoint, they had an aggravation of underlying asymptomatic pre-existing condition. And depending on the severity of AVAS necrosis, if they have had patients that are kitchen workers and slip and fall in the kitchen, and they've had normal hip from what they thought, but they have AVAS necrosis and suddenly have collapse of that. So in that standpoint, I mean, the cat's out of the bag and they need a hip replacement. That's a common scenario. Alternative ones is I've seen people with, like you touched on before in question, patient comes in with a labral tear, but they have some underlying AVAS necrosis as well. In those patients, I think it's prudent to treat both. But ultimately, how AVAS necrosis is a difficult disease to deal with in the hip because how it progresses in people is very variable, even amongst individuals. How fast it progresses is variable. Some people, from the time of onset of symptoms to collapse of their head, could be months. Other people, it can be a slow, steady process. Yes, sir. Yeah, so with the metal on metal, so to back up a second, we thought, going back to early 2000s, because of all the plastic debris that was occurring in osteolysis, we thought that was going to be the next greatest thing in orthopedics and hip replacement. So they went to metal on metal bearing surfaces. The problem is that if the hip is not putting, a lot of these patients with metal on metal do okay, but if the components are not putting correctly and there's some abnormal wear at the edge, it can give off metal particles, specifically cobalt and chromium around the hip. back up a second, to follow these patients, usually we do so, if they have a metal on metal hip, the recommendation is to check screening levels of them on an annual basis and follow the trend. That the actual numbers are not as important as the trend of the numbers, but if they're elevated, do some kind of advanced imaging, typically a special MRI called a metal subtraction MRI. It's the most sensitive. They look for fluid collections or what's called pseudotumors around the hip, where these metal particles can eat away at the muscles around the hip, can eat away at the bone. It's really quite impressive when you get in there, but it can cause severe damage around the hip, and that MRI looks for that. And if there's any evidence of that, the recommendation is to revise the hip because it can cause further damage. If the patient has a well-functioning asymptomatic hip with normal metal ions, then the recommendation is to follow.
Going back to her question, do you have an opinion on whether there's a causal connection between the kitchen worker who fell on an asymptomatic hip that did have a vascular necrosis and the need for treatment being related to that fall?
Yeah, I mean, I see a lot of patients with AVAS necrosis, hip arthritis that are asymptomatic. They deny any pre-existing symptoms. They have pretty significant radiographic findings, and they, in my mind, have a pre-existing asymptomatic condition that gets aggravated. And, with AVAS necrosis, it's a lot less predictable than arthritis, and then with arthritic patients, that sometimes you can settle them down and they go back to their pre-existing baseline state. If a patient with AVAS necrosis, if that fall or identified collapse on X-ray where the sinkhole sinks, I mean, that's a poor prognosis. That patient's not going to do well.
And all of the subsequent treatment would be related to your injury?
Yeah. I mean, that's...
Facial pain.
Yes, sir.
Doctor, on anterior versus posterior approaches for hip replacement, do you encounter any more resistance in the insurance carrier as we're doing the anterior as opposed to the posterior approach?
Yeah, so for his question was, is there any insurance differences? So the insurance is billed, as you know, based on CPT codes. There's one CPT code for hip replacement, a different one for hip resurfacing, unlisted procedure, but 27130. It does not specify how it was done, anterior versus posterior, if you used any special robotic instrumentation. From my standpoint, I mean, I'm very good at both. An anterior hip replacement takes me about an hour. The posterior one takes me about 45 minutes. So it takes me about 15 minutes longer to do that, but I don't get paid anymore. But I do it because I think it's better for the patient. The patient does better, and they're going to come back happier. But in terms of payment, you get the same payment. Thank you for having me.
If somebody wants to drop a watch,